Yeah, we can get started.
All right, doctor, you are now live.
This is Dr. Deukmedjian. We're starting a last surgery of the day called the Deuk laser disc repair. Watch the needle there. This patient has a degenerated disc, collapsed disc, herniated disc at L4-5 and L5-S1, and he's having pain down his right leg and in his back, and we're going to try to fix that today. All right, shot. Yeah, I know. It's not. We'll get you more comfortable in a minute. Just bear with me. Shot. Okay. Gonna have to start a little bit higher, I think. Let's see. That's just my hand pressing around, okay? Shot. That's got to be his. That's his iliac crest. I'm going to start a little bit more medial. Shot. All right. So a lot of times with the iliac crest, you want to start a little more medial. That will help you. Especially at L5-S1. Shot. Okay. Now, can we clean up L5-S1? I know it's pretty bad, pretty collapsed, but I'm just wondering what we can do to make it better. Are you trying some orbit there? I think that's off there. Let's, that's probably worse. How about the other way? So right now at the beginning of the surgery, we have to get the x-ray machine lined up properly. I would keep going. Let's see what that does. Keep going. I think you're past it there. Let's go back a little bit. That may be the best right there that we're going to get. Let's see what we can do. Shot. Shot. I know it's uncomfortable, but let me know if you feel pain down your leg, okay? Shot. I don't expect you to, but you might. Shot. And he's got a lot of arthritis down here, so we got to make our way through it. It's not an easy thing to do. Let's get an AP. Shot. All right, let's go back to a lateral. Shot. Shot. Awfully close. Close, but no cigar yet. Shot. Let's get another AP. Our patient has a lot going on with the spine in terms of what we call deformity, bone spurs, things like that. Back to a lateral. Scoliosis, kyphosis, listhesis, degenerative disc disease. There's a lot going on, especially at 3-4. It looks like he fused himself. However, our problem is not there at 3-4. It's actually down lower at L5-S1 and L4-5. We don't have a lot of room to work through here. Shot. So I've got to find a way to get down to what we need to fix using very small window. Shot. Trying to get around all the bone spurs. Shot. Shot. You feel that in your back?
Yes, yes, ma'am. Yeah.
Just getting caught up on the facet, it looks like. Sometimes it's just some arthritis. You can get through it. Other times it's more than that. And it's actually bone spurs. And there's no way around it. Shot. Let's go with an AP. You're doing fine, okay? I'm working on getting into that bottom disc, and that's the worst one. I'm close. Very close. I'd like to be closer. We're going to get closer. You okay? You're doing good. Just lay still. Don't pick your head up. You're fine. Let me just work on this for a little bit. I think we have an orbital issue. Do you see it? Huh? See if you can change the orbit a little bit. Try the other way, just a degree. I can't tell if that made it worse or better. I think, you think it's worse? Try the other way. I think it might be better, but try the other way. It's fine. What?
Go a little bit more.
We're right behind that disc. Shot? I think it's the other way. I really do. Yeah, you got a double shadow on the back of the vertebral body. A little more. To me, that looks better. Give me an AP. But I admit it's very hard to tell because of the scoliosis is so severe. And we're right there. Right there at the entry of the disc. Right there. And there's so much bone spur there. That's the problem. So much bone spur. We're in the right spot, but it's like closed down on me. A lot of times we can work with this though and get it to work when the patient's asleep. Because sometimes it's their discomfort, shot, that keeps them from allowing me to get into the disc. But I feel like I'm close enough. Okay? All right, well, let's try the next one. I'm going to have to make an incision anyway.
Yes, sir.
So I'm going to see. Give me some more numbing medicine.
Yes, sir.
All right, let's line up for 4-5 because that's what we're going to be doing next. and make our little 7mm incision. And then now L4-5 is not much easier. Shot. It's looking pretty good. Shot. Right there, shot. So we're on track, on target, but again, running into the same arthritis. Shot. We will get around it. I feel confident about that. How you doing, buddy? You okay? All right. Shot. I'm right there, the back of that disc. Shot. You okay? How much of your problem was back pain? Huh? Most of it's back? Sir, doctor, what percentage is your back versus your leg? More leg than back? So we're going to do a discogram at L4-5. I couldn't get into the L5-S1. I'm right at the back of it with the needle. You comfy? You're not having any pain? All right. How bad is that on a scale of 1 to 10? How high did that go? How high? How high did that go on a scale of 1 to 10? Doctor, I need your help. I can't hear him.
Can you tell me how bad?
How bad was that pain on a scale of 1 to 10?
Okay, from 1 to 10. If 10 is the worst.
At least 10. All right. Is that where you typically get your pain? Yeah. All right. So that's concordant, 10 over 10, 10 plus over 10. All right, doctor, we can put him to sleep. You're going to feel a little burning in your arm. That's the propofol going in, okay? When you wake up, we'll be done with your surgery. You did very good. I want you to count out loud from 1 to 100, okay? Count out loud for me, 1 to 100. Now. And don't stop. So basically, we're in the disc at L4-5. We tested it. It's definitely causing his pain. He had 10 out of 10 pain at L4-5. 10 out of 10. He almost jumped off the table. You all heard him, and he arched his back up. So when I tested the L4-5 disc, he has 10 out of 10 pain. We need to drop the table about half an inch. All right. You can see, why don't you show the audience the tear in the back of the disc at L4-5. That area where the white arrow is, that tear right there, the black stuff, that tear and herniation is where his pain is coming from. We're going to go fix that first. Is he asleep, doctor?
Yes.
All right. Now that he's asleep, shot, I want to go ahead and proceed with the surgery, shot. I can't see my guide wire yet, shot. Because that dye in the disc. No, lay still. Lay still. I want you to count from 1 to 100 out loud. You're supposed to not stop counting, okay?
1, 2, 3, 4.
Shot. Keep counting. I can't hear you. So obviously we want him to be asleep. And Once he's asleep, we can proceed. The guide wire is in as far as it'll go. This is a pretty collapsed disc at 4-5 as well. So I'm going to come out with our needle, leaving the guide wire in place. Shot. That looks good. Now, through the incision that I made, I'm going to bring this dilator down over the guide wire. Is he doing good? He's a little more oozy on the blood than normal because he does take a blood thinning agent, which he stopped 10 days ago. Shot. But it still has an effect. Even if you stop it 10 days ago, there's still going to be an effect that lasts or endures. It's just we want most of the platelet and clotting activity to be there. All right. Okay, so we are working on L4-5. We're going to advance this dilator. Doctor, are we ready?
Yes.
All right, so I have my tip of my dilator in the foramen right at the disc, the bad disc, and I'm going to just gently advance it while the patient is asleep. Because he's asleep, he won't feel pain. He's going to let me advance this thing into that painful disc. And you're going to see it'll open the disc up. Literally open the disc up, open the vertebrae up, spread them apart, and allow me to get into that disc. I can tell you already, this disc is not going to, there's not going to be a bunch of disc in there because it's very collapsed, very degenerated. This problem has been going on for a long time for him. And when you let these kind of herniations last for a long time, what happens is that the disc gets destroyed structurally. It gets destroyed. All right, so what's an example of that? Rust. If you have a car and you let the paint come off of your car, you're going to start getting rust. And the problem is if you don't fix it quickly, the rust gets worse and worse. You've all seen those cars, right? They have the whole bottom of the car is rusted out. It all started with one little scratch in the paint that got water in it and over time oxidized to the point where all the metal is destroyed and it's just rusted through, especially in areas where there's snow and salt. You'll see those bottom of the car, come on guys, is all eroded away. Is he okay? Shot? So that's what happens to a disc. If you want to go, you can. You don't have to stick around. That's what happens to a disc, by the way, is that over time, if you don't fix it, when you have a herniation, watch this area here, it will degenerate. Shot. And the degenerated disc will collapse. And it'll make structural changes that are permanent to the disc that are irreversible and can never come back. I hate this part. This is where we have to take the dilator out of a collapsed disc. It's a pain in the butt to do. Shot. And made some progress. Is he good? We have special tools we use to get these dilators out in tight compressive situations like this. We may actually bend our tube. Huh? Another bent tube. No, I don't know if it's bent yet, but I wouldn't be surprised if it is. So now what I'm going to do is work my way out of the disc from inside out while I'm removing the herniation, removing the bone spurs, and getting rid of debriding the annular tear that's inflamed. Because that's where his back pain's coming from. Did you see how much he arched when I did the discogram? I just injected a little material and he almost came off the table. The reason for that is...
Wait, you see these lines? That's it too. That's where
Because that's a painful disc for him.
You have to.
And if the disc wasn't painful, he wouldn't have noticed it.
Yes.
Look, this metal has to point to where that is, so you have to adjust it. Okay? All right, let's see.
The camera.
All right. All right, let's go inside.
Scrub on.
Take a look at what's going on inside this disc. I can tell you this will be a very degenerated disc already, that most of the disc material will be 100% gone, but there's a little area in the back where there's a tear, and that's where all the pain's coming from. So we want to go and treat that area. The blue stuff is the herniation. And once again, there's not going to be a nice pillow of disc here because this disc is probably 99% degenerated and collapsed. Maybe 95%. That's not the concern. A collapsed disc doesn't cause back pain. Okay, that's a big falsehood, misunderstanding, misrepresentation, whatever you want to call it. It's not true. Collapsed discs don't cause pain. It's the annular tear that causes the pain. And that's what we're here for. We're here to kill the dragon that's causing this man's pain, and that's it right there. That's part of it. I just got to focus this thing, and now we're ready to rock and roll. Irrigation good? Thank you. You know, if there was a band, you know what you would be called, Crystal? If there was a band. Yeah. You would be Crystal Method. All right, so right here, folks, this is the source of pain in his back and his leg pain. Right there. Okay? There is a piece of herniation down there I need to go get. Right there. Right there. And I can tell you right now, it's hard. It's hard because it's full of calcium deposits and bone spurs. The longer you let your herniated disc go, the more scarred up, collagenized, and hard it gets. It just gets real thick and hard and destroyed. So the best thing that could have happened for him was to find me. But if he could have found me a few years ago, like 20 years ago, he could have probably avoided his disc from collapsing. Look at that right there. That's beautiful. That is the source of his back and leg pain. That's the annular tear posteriorly in the disc. Yeah, I think this tube is going to be crushed. At least they're not as expensive as they used to be. So, doctor, he's responding. This is the more painful area, part of the surgery. This is that painful disc. So I don't mind him moving a little bit as long as you're happy with where he is. I don't mind a little bit of movement. I just worried it's going to get worse. Yeah, he's really moving more now. So sometimes patients move because they're feeling pain and there's a reflex pathway where they move their body, and sometimes they're consciously aware. We don't want our patient to be consciously aware. I don't think he is. But if we can get him a little bit more comfortable, then maybe he won't respond at all. You're doing great. Lay still. Now, the thing about anesthesia, for those of you who have never experienced it or studied it, is that there's not one dose that works for everybody. Everyone's different. Some people require more. Some people require less. All right, yeah. He's still moving a bit. But it's not terrible. And really the safest would be for the patient to be awake. Unless their heart races, and then they could have a heart attack. But you always want to have a balance between the patient being awake enough that they're breathing and not obstructing their airway, but also comfortable enough that they don't have a hemodynamic reaction. And of course, you don't want them moving around the operating room, trying to get away. Right?
He's doing fine.
Yeah, no, he's fine. I'm fine. He's doing really good. Yeah. And that right there is what we came for. That thing right in front of us. It's kind of like in the movies, you know, with a horror movie when there's the alien or monster. At first, the people have no idea what they're looking for. But then once you've identified it, you know what it looks like, you know where it is, you go get it. Anyone see the movie It?
Yes.
Huh? Too scary for you? Really? I love scary movies.
I like thriller or more of like the brain ones. Yeah, like where they're like a thinker, but if it's anything that jumps out, I don't like that.
You like those kind of movies. Have you ever seen the movie called Seven?
Yes.
Yeah.
It's very good.
That's a great movie with Brad Pitt
Yes, yeah.
and Morgan Freeman. Oh my gosh. That's an oldie.
Yeah, that was the late 90s or early 2000s.
Yeah.
That was really a good movie.
That's a great thriller. And Kevin Spacey. You like space movies? Like sci-fi?
Yeah.
Me too. I love sci-fi. I grew up reading sci-fi like L. Ron Hubbard. Any questions from our audience, Diego?
Yes, we have a question. We have
Before we
some.
take it,
Yeah.
before you take the question, why don't we do this? Let's run a video for our audience
Okay.
on why do people have back pain from a herniated disc? What's the cause? And the answer is inflammation.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, good. So we're here inside the endoscope, still working on the annular tear. That's what you're looking at right here at 12 o'clock. And Diego, why don't we do one more video animation? Show them what the Deuk laser disc repair does for the lower back, how it works.
Disc herniations
Okay.
are a common cause
do
of
that?
chronic back
Yes.
pain.
Wow, look at that.
The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
We're live.
Awesome. All right, so we're still working on this tear at L4-5. We're almost done. This is pretty much the end of L4-5 right here. What you're seeing, this pink stuff, is inflammatory tissue. And I've been telling you all for a long time that this disease that causes back pain, neck pain, it's an inflammatory disease. It's a disease of inflammation. And these patients suffer with chronic inflammation in their disc. All right, I'm going to have to go in and get that out. Laser off. So I was going to have Jordan stay later and let you go home and let him just go a little earlier on Thursday. But, I mean, you guys don't have anything going on, right? So why not have him work late today? You know what I mean? Laser? Right, but what I'm saying is since I'm not operating Thursday, you could go home, let him work here and get his hours. And then that way he wouldn't just sit around doing nothing on Thursday. You know, trying to be efficient. Next time. Okay, that is about it right there. The last of the herniation. There's some bone spurs. I want to get rid of all this stuff with the laser. And that will decompress the nerve root and treat his back pain.
Deuk, are you ready for a question?
Yeah,
Okay.
I'm ready for the question, sure.
We have a comment from YouTube that says they are having surgery tomorrow for a pinched nerve on for their lumbar stenosis.
Yes.
Their doctor says the surgery is going to take about an hour. She thought it would take longer. What's the average time for such surgery?
Well, I don't know what surgery you're having. So somebody's saying they're having surgery for a pinched nerve in their lower back. Unfortunately, it sounds like you're having a microdiscectomy, which I don't like microdiscectomies because they're going to drill away your bone. And they're going to take normal bone out of your spine that shouldn't be taken out. They're also going to take out part of your facet joint. But a normal microdiscectomy does take about an hour. Again, I don't do them anymore. I do these surgeries instead because we're not taking any of the bone out of the spine with this. Why don't you run the microdiscectomy video so that they can watch that and see what I'm talking about with microdiscectomies and why I don't like them.
Okay.
Just to make you aware, not to freak you out. Don't take it the wrong way. All right, grab her. Are you running? You got to tell me when you're running.
Yes, we are.
Just say. It looks like it was schmutz because I don't see it anymore. Yeah, no, it's still there. You see it? At 7 o'clock, yeah. It's like a shadow. You see it? It's not schmutz, it's lens. Why don't you look at the scope? We may need to have the scope repaired. Laser? As soon as I go in, you got to get the laser on, okay? I shouldn't have to ask. Oh, no worries. I'm just saying. So as you can see, microdiscectomy is an old surgery, been around a long time, and the surgeons have to remove all the normal parts of the spine in the back just to get to the herniation. And even then, they don't get the whole herniation out like we do here with the endoscope. I don't like microdiscectomy because so many people end up coming back having additional surgeries and treatments for it. And it causes a lot of problems for people. It doesn't treat back pain either. It only treats leg symptoms. So if all you have is leg symptoms, that's fine. It might be very helpful for you, but it is going to cause some damage to your spine. We're done here. Man, some blood vessels. Looking pretty good. All right, laser off.
Lights on, please. Scope off, please.
The nerve root is going to be just here, but we have a little bit of venous bleeding. Not a big deal like for the patient's safety or anything, but it just obscures the view.
Yeah, scope off.
That's a vein right there. Do you guys see that little vein at the end? That vein is there because there's so much inflammation, and inflammation brings more blood vessels with it. So if it's been going on for a long time, it'll actually cause more blood vessels to come. All right, why am I not able to get this down? Hey, lay still. Lay still. You're doing fine. I should be bent here, right? I'm going to need a lot of irrigation. Give me some more, please. Yeah, why don't you check the tube as soon as it comes out? All right, what other questions are there, Diego?
We have a patient asking about their experience at the chiropractor and where they were told that their hips were tilted. They want to know, what does that mean?
Chiropractor told them their hips are tilted. I don't know. I'll be honest with you. Chiropractors say a lot of funny things. Take this. Let's get him back to sleep. Lay down. You're fine. Everything's going good. Honestly, I have no idea what your chiropractor means by your hips are tilted. It could be that you have one leg longer than the other, called a leg length discrepancy. It could be you have some scoliosis. Honestly, don't know. It's not a standard lingo. It's not like saying, this is a hammer. This is a hammer. But my hips are tilted. Have no idea what that means. Chiropractors do say a lot of funny things, I will warn you. Chiropractors' reimbursements have been cut. And so what they do is they look for ways to get money that are, by making some funny diagnoses. That's the only thing I think you got to watch out for with these chiros. Chiropractors are really good. They do a lot of good stuff for the spine. They do manipulation of the spine. And you can't make a generalization. They're not all bad. But some of them are just out to do a bunch of tests to get money or treatments to get money. and so they make up these weird diagnoses and they order these weird tests that nobody else orders or does. And as a spine expert that I am for 26 years, I can tell you there's absolutely no reason to get those kind of tests done except to make money off of them. So I don't believe in doing that kind of stuff, but a lot of chiros are order a bunch of weird tests and make some weird diagnoses that nobody else ever understands or agrees with, you know, in order to initiate a treatment that is for that weird diagnosis, because of course a surgeon is not going to treat it and no one else is going to treat it because there's no such thing as that diagnosis. Yes. We need the table up. What is it? Oh, bend? How did that bend? What did you do? I'm kidding. What's your elbow there? Ah! That's an expensive piece of equipment. Wow. So the disc was so tight and compressed the tool so hard that it bent the instrument, piece of metal. It bent the steel. Okay, are we ready? Alrighty. Can you give me an AP view? Just tell me when you're ready to shoot it. So what we're going to do here, this guy has moved a little bit, but we're going to basically try to figure out where we are exactly with the needle tip. Shot. So we're right at the entrance to the back of the disc, which is where we want to be. Based on that picture and based on the lateral. Go back to a lateral. So I wasn't able to advance this needle into the disc because it's too collapsed and there's too much bone spur and scar tissue and inflammatory tissue back there. So what I'm going to do now is I'm going to try to do it under fluoroscopic guidance. I need you to, I don't know if it's a WAG issue or a rotational arcing issue. We're definitely off on arcing. So try to readjust the arc. That is worse. It's the other way. That is better. Yeah, it's not too bad. I don't know. It's kind of hard to tell. All right, we're going to make a good Boy Scouts effort to get in there and get this level fixed. So, I think the WAG is off. It's hard for me to say for sure though, because there's so much twisting and warping. That's actually where I think we need to be, right there. Let's try that. All right. So here we go. I need the guide wire. Do you have that bent dilator? I want to show the audience the dilator. So this is what happens when the disc is so collapsed. You can actually damage the steel, the surgical steel. Look at this thing. Can you guys see how it's bent right here?
Yes.
That's amazing. Yeah, that's from being inside between those bones. That's how much force there is on the disc. It bent steel. That's bent surgical steel from the bones in the disc space. That's how much pressure is in the disc space. All right, shot. All right, I hope that guide wire is where I want it to be. It looks good. Shot. Uh-huh. Yes. Good. Shot. All right. Let's have the dilator, the new one. We've already destroyed one dilator. We're going to need to order more dilators, Luis. Shot. Now, I'm using the guide wire as a marker to get down to where I need to be. Shot. As long as it doesn't move substantially, I can safely navigate down to the disc. And once I get there, if my anesthesiologist has him asleep enough, I need you to give me maximal sleepy.
Yeah,
Shot.
right now
As long as you give me maximal sleepy, I can try to get into this disc that doesn't want to open up. Shot. And it's not going to be easy, I can tell you that. It is not going to be easy. This may be my hardest ask that I've ever done. Shot. But we're there. All right. Is he okay? All right. I'm going to give it my Boy Scout best effort right now to get into that disc. As long as he's deep, we have our best chance. So you let me know if you think he's deep enough, and I'm going to go for it. Shot. That's about as good as it gets right there. Give me an AP. Or right there in the frame and at the back of the disc. As long as he's deep, he won't like tighten up his back muscles. So we'll be able to hopefully slide in there. Yeah, we're right there. All right, back to a lateral. We're going to go for it, folks. Don't say that. Don't jinx me. Shot. Uh-huh. Shot. Can you get it back to where you had it before? Oh, he may have moved a little too, so it's hard to say. But you were lined up with the back of the disc, with the tip of my dilator. Yeah. I think you got an orbital issue. Again. Shot. That's better. Now a WAG issue. Other way maybe. That's better. Let's hold it and see what happens. Shot. I know, that's terrible. Yeah, that is not wanting to go in the disc space. Let me have the remover. Yeah, put that on there. All right. Where's the long skinny needle? Don't put your hands here.
You want a 22?
We're done, doctor. Yeah, the 22.
What is okay.
What? I don't understand. I thought you had one.
No,
Oh,
no,
just
no,
cervical?
yeah,
No
but
problem.
Sometimes you can actually.
Let's see. We're done. You can wake them up.
Lights on, please. Oh. Yeah.
Oh, there must be some schmutz in there.
You want the guy one?
How is it one side works, the other doesn't? And one hole takes this needle and the other one doesn't? That makes no sense. All right. Well, you're gonna have to clean that out. Okay. Well, we attempted 5-1 and I was unsuccessful at getting in. But I think we were able to get some of the bone spur in there pushed into the disc. So hopefully deflected away from the nerve root. All right, any questions from our audience? There's the incision. I think he's going to have a really good result because the L4-5 definitely causing pain. L5-S1 we weren't able to get into. It's too collapsed. Yeah, it's fine. Go. I got a Ray Tech off the field. Go ahead and type up your questions for me, and I'll come answer them for you, folks. In there, it's all natural. Are you glad you did it?
100% glad I did it.
Yeah.
I tell the story all the time. Everyone goes, "Oh my goodness, you had back surgery. Are you okay? I can't believe, how are you walking around and you look so comfortable?" And I tell them, I don't have anything in me. And I tell them how the surgery went, and I don't mind showing them the video, and they're blown away. And so I often share your website and number with many people.
Thank you. Dr. Deukmedjian here with one of my patients who actually happens to be a musician and is here in the local high school, right? A very large high school for that matter.
Yep, absolutely. The largest in the district.
Largest in the district. And you have how many members in the band?
160.
160 students in the band, and he is the director of that program. Tell me about your back problems before we did your surgery.
I was an active runner and exerciser, and I was out, on a very long run, 15K, and I noticed a pain running down my leg. I thought it was due to poor stretching and not enough stretching, so I increased that. It wasn't going away, which was a red flag indicator, and I saw my doctor, who then recommended an MRI to see what was going on. And it showed the herniated discs, the L4, L5, L5-S1, who then recommended me to go to another center to receive back surgery. To which, and I had told you before, my wife saved the day and found you guys.
They usually do. The wives usually do. They keep us out of trouble.
Yes, she often does. So, when I came to see you with that same problem, with the pain shooting down my leg, I would say at days, 9 out of 10, I would have to call off of work, sit at home, or lay at home, honestly, just to stay off of it because the pain was so great.
Yeah.
Yeah.
So it really had, the pain in your back and down your leg had a really bad effect on the quality of your life and your ability to do your job. And what did the other center, by the way, what did they recommend in terms of treatment for you?
A fusion.
A fusion, right?
Yes.
So you didn't want a fusion.
Absolutely
You didn't
not.
want a fusion. You didn't want to lose the natural movement from your lower back. And you found out, your wife found out about our laser surgery, which preserves movement by not fusing. And we don't put anything in your body and leave anything in there. So your back pain that you had before surgery, which was done 6 weeks ago, by the way, how much of that pain do you still have?
0.
Gone.
0.
Cured.
Yes.
Awesome. And the leg pain?
It is gone. Yeah, the pain shooting down my leg has completely gone away, and it is wonderful to be able to climb the bleachers in the stadium, to get on my podium, and to be able to play my saxophone comfortably.
Awesome. Well, congratulations. You had the courage to do the surgery and have the laser surgery repair your disc, and here you are 6 weeks later doing fantastic. Please tell your wife, give her my best regards. Okay?
Thank you so much.
All right. I have a very special patient sitting here next to me who's traveled all the way from Tennessee
Yes, sir.
with his family for one purpose, and that is to get his neck fixed.
In the wild, I've trained animals for 25 years, not jumping through fiery hoops, but just mostly behavior, no, come, just a few words. We had 52 big cats, tigers, lions, leopards, cougars, lynx. This is me about 6 years ago in the tiger cage. And this guy here, we raised him from a baby.
That's special.
I'll tell you what, the special part is being here.
And how long have you been dealing with this problem with your neck?
It's come on in the last 8 weeks strong, but after I start thinking about it, even 6 months ago, I was seeing things happen that I couldn't understand why. And I just want to get back to somewhat where I was at and get the feeling back in my hands, my stability, a little strength where I can get this boy up.
Well, what's going on, as we've talked about, is you've got these herniated discs, bone spurs in your neck that are pinching down on your spinal cord and nerves. And I'm going to go in there tomorrow with a laser, and we're going to open all those spaces up, get the pressure off the spinal cord and the nerves, so you can start getting some feeling back and strength back in those arms.
That sounds great. That's why I'm here. Then I've researched, and I kept coming back to you all and seeing the testimonies and seeing, watching hour after hour after hour of the surgery. And that says a lot if you can do it live on Facebook. It's just a pleasure to be here. I feel safe. I feel like when we arrived last night, we drove up in front of the place, and I told my crew and my wife and my driver, I said, we have arrived. We have arrived. Thank you so much.
We'll see you tomorrow morning, all right?
I appreciate it so
All right,
much.
so we did surgery yesterday with the laser. Everything went really well. You can actually see the 4mm incision right there, 3 discs. He didn't want fusion, and so he found Deuk Spine Institute and he came here.
After the surgery when I talked to you, I was still a little bit drowsy. And 4 hours later, we were sitting over at a restaurant, seafood restaurant, eating seafood, and I could clap my hands at the baby because he claps when he does something good. And I could clap with him without missing my hands.
And you're already getting strength back in your arms and legs. You're getting control of your bowel and bladder back again. That's great news. It's a great sign. I think you're going to keep improving and hopefully get you back to normal.
You are the best. That's why I'm here. That is why I'm here. It is amazing. From the time I walked into this place, I felt at home. I felt like I was with friends all the way through surgery. When we walked into this surgical room, everything's so clean. I feel like I'm in a dream. I really do. Thank you so very much for what you've done.
You are welcome.
How to request a free MRI review. Who are we and what we do? With world-class physicians on staff, the newest and most advanced technology, Deuk Spine Institute has performed thousands of procedures and achieves a 95% success rate in elimination of pain. Treatments? Every patient comes to us with a unique set of challenges. That's why we address every patient's care individually. These are some of the world-class treatment options available at Deuk Spine Institute. Deuk laser disc repair, Deuk spinal fusion, rhizotomy, epidural injection, kyphoplasty, physical therapy. Meet Dr. Deuk, world-renowned board-certified neurosurgeon. Go to www.mri.deukspine.com. Click the Free MRI Review tab on the upper right. Complete the patient information form. Continue to fill out Step 2 of the form. Make sure to submit all your MRI images, plus report. You can submit the MRI through the mail, file upload, or medical record release. You can drag and drop or upload images into the form. Things to remember when submitting your free MRI review. All MRI images must be submitted along with the report in order for it to be reviewed. Once your case is reviewed by our team, a patient advocate will contact you. Thanks for choosing Deuk Spine Institute.
I'm Dr. Deukmedjian. We're here with one of our patients who traveled to here from Texas, correct?
No, Auburn, Alabama.
Sorry, Alabama. All right, so Alabama. And why did you come to Deuk Spine Institute?
Because the last flare-up of L4 that ruptured in 1999 was unbearable, and my wife can be a testament to that. Who took care of me for 10 days, crying on the floor with an amazing, incredible pain.
Okay. And you've had that pain now in your lower back for 22 years?
Yes.
You've tried physical therapy and exercises, stretching, but none of those things worked?
No, temporarily.
Yeah. And where was your pain coming from? Do you know?
It was around the belt region in the back, yeah.
So the L4-5 and L5-S1 discs had tears and they had inflammation and pain. He also had sacroiliac joint inflammation and pain. And Dr. Patel standing here, which we don't get to see you very often, but Dr. Patel was a hero. He came in and did the bilateral SI joint injection.
Yep.
So do you still have the pain in your back that you came here with?
No.
It's gone.
It's very, very gone, yes.
Excellent. Well, it should stay gone. Is there anything you want to say to your audience?
Well, I think
Yeah. Hello, I'm Dr. Deukmedjian, and you just watched the Deuk laser disc repair done on a patient's lower back. And this gentleman was actually born in 1944. So he was born around the time of World War II. He's an older gentleman, and he had two discs that were collapsed at the bottom of the spine, L4-5, L5-S1. And I really tried to get into the bottom disc, but I couldn't get in there. The approach that I take, forget about the metal here, that's not important. The approach I take is basically coming from the side and going past this joint here, the facet joint, which gets a lot of arthritis in it, and it did in his case. And then I enter the disc right here. Okay, and then to get to the L5-S1, you've got a tiny little window right here, and then you can get into that disc right there. You see that? Okay, so that's how I approached his L5-S1 through this tiny window. Problem is there's so much collapse of the disc and arthritis right here where the tip of the pin is, I just couldn't get in. And it was actually forcing my dilator to go down and away from the disc because of this bones here, and there's nothing I could do about that. So I made an attempt to get in, I just couldn't get in. But I feel like we probably opened a little bit of room in there for his nerve by pushing the bone spur here in. So I think he's going to get some leg pain relief from it, but definitely this disc was causing 10 out of 10 pain when I tested it. I fixed that disc, and I think he's going to do fantastic. The only other thing we could do for him is basically a fusion, which he doesn't want, and I don't blame him. So sometimes you do the best you can, but the patient's anatomy will keep us from achieving the goals that we set out to do. It's not common. It happens probably about 1 every 50 to 100 surgeries where I cannot get into L5-S1 for some crazy reason, and basically hypertrophied or enlarged bones and joints, collapsed disc, rotating spine, slippage, high iliac crest. Those are all factors that contribute to my inability to get into that L5-S1 disc. But that said, I think he's going to do very well and be pleased with his results. Do we have any questions?
Yes.
Does this surgery work for central located herniations?
Does this surgery work for centrally located herniations? The answer is yes, it does. And it's a great question. So let me show you what I'm talking about. If you look at the disc and where it lies, you can see that it goes from pretty much one side of the spine to the other side. And so there's a part of the disc that is kind of out here to the side. We call this the foraminal area of the disc. And then there's a little bit closer to the midline is the lateral recess area of the disc. So if you're looking at it, imagine there's a disc right here, okay, on this bone. You have the central area of the disc, okay, and here's a central herniation, basically a herniation in the middle. And then you have the lateral part of the disc right here, which is the foraminal and lateral recess. So you got central, lateral recess, foraminal, and then extraforaminal. So the question is, we know the surgery works for these foraminal and lateral recess disc herniations, but does it work for a central herniation? And the answer is yes, it does. Why? What you have to do with a central herniation is you have to change your angle of entry. And instead of going in the skin here and coming down like this into the tear and herniation in the foramen, you got to actually enter further lateral, and you got to be careful because this is where you can get into trouble. If you go too far lateral, you can hit the kidney, or you can get into the abdomen and hit the intestines, which is really bad. You don't want to do that. So you got to make sure you never do that. So there are some tricks you can do to get more lateral on your entry. So you come into the foramen and you skim across the back of the disc, and you can get that central herniation. It's definitely doable, and endoscopic spine surgeons worldwide do it. I'm not the only one who can do it, but endoscopic spine surgeons that do this kind of surgery, yeah, we can do that. And like I said, if you look here, you know, again, instead of coming at this angle, you want to come more lateral, and you want to angle more medial at where the disc is. I don't know if you can see that. So it's doable.
Does the MRI show annular tear in the disc?
Does an MRI show an annular tear in a disc? The answer is yes, but it's hard to see sometimes. And what you have to look for is, what I look for and what I use the MRI exclusively for are two sequences. One is called the T2 axial, and the other is called the T2 sagittal. And basically the axial view slices through the disc like this. It just like slices through the disc like that, and then you're looking top down. So you kind of look at the disc like this, and what you're going to see with a annular tear is you're going to see a change in the contour in the back of the disc. So instead of the back of the disc being concave, where it kind of dips down in the middle, okay, you're going to actually see it flat across. So you lose that dip, and that means there's a tear there, and there's herniated nuclear material in that tear. Otherwise, it would be dipped down. So kind of like the difference between here, maybe you can appreciate this. I'm looking for a model that has it better, but you can see this almost kidney bean shape, this dip right here, okay? So when you lose that dip in the back of the disc on an axial view, it's because there's a tear here and there's nuclear material in there. Radiologists miss this stuff all the time. And then, of course, if you have a tear laterally over here, you'll see gray material, which is the nuclear material, should be here. You'll see it out to the periphery. The key is looking for that gray material, which is the nucleus pulposus, should never be out at the periphery of a disc. It should be contained in the middle, and there should be the annulus, which is a darker color. And that way you know the annulus is there and intact, but when you see grayish color pushing out to the periphery of the disc, that's an annular tear, and there's a herniation there.
And then lastly, we have a long-time viewer. Says he canceled his cervical fusion after watching you.
Okay.
And now he's trying to find someone close to you that does the surgery, but it's only you.
Well, that's awesome that you watch. So one of our viewers has canceled their fusion surgery from watching me. Thank you. That's a compliment, I think. And it means that the message is getting out there. Obviously, if you can, get the laser surgery done. And if you can't, come to me and I'll try to do your fusion for you. But obviously, fusion is in my opinion, way overutilized. I was guilty of doing fusions, a lot of fusions. I did them because they work, okay? If you do the fusion right, they work really well. And they will get rid of the pain, but you're stuck with all this metal in your body and scar tissue and pain and suffering after the surgery, and of course the risk associated with fusion. So there's a lot of negative with fusion, but there's also good that comes from it. Now, before the endoscopic laser surgery was available, which was only 15 years ago, before I could do those, fusion was really the best. It really works and it's safe, whether you do it on the neck or you do it on the lower back. I mean, it works really, really well if you do it right. But now with the endoscopic surgery available, it's really hard to justify fusion at all. It's just so much better, minimally invasive, repair the disc, don't fuse it. Yeah. So I appreciate your sentiments and comments. I wish you were able to get out here and get the endoscopic laser surgery done. Hopefully someday you will be able to. All right, well that's it. It's been a long day and I appreciate everybody watching and learning. Check out our Deuk Spine Scams Exposed. It talks about, these are videos that we talk about issues not necessarily directly related to herniated discs and surgery, but kind of like some of the peripheral issues affecting the spine world. And people need to be aware of these issues because there's a lot of bad stuff going on in spine that people really need to be aware of so they stay out of trouble and they don't get caught up in it. Artificial discs are one of them. And in my opinion, they're dangerous. They don't work well. There's a lot of people who have them done and they have problems. Yes, you could say the same about fusion, but if you do the fusion right, your results are going to be better, in my opinion, in my experience, a lot better with a good fusion than an artificial disc, especially when it comes to the lower back. When you're dealing with the lower back, the only way to put an artificial disc in is right through your belly. And there's a lot of bad things that can happen going through your belly that you don't have when you go through the back to do a fusion, a T-lift. So, yeah, just trying to raise awareness of the complex issues involving spine care in the world and make people more aware of the facts and the truth. And that's really what our job is to do, really, make people aware of what's out there and what's available and the truth. And then you make decisions for yourself about what's best for you. Have a great night, and we will be back next week. We don't have surgery on Thursday this week, so we'll be back next week with more surgeries on Tuesday and Thursday. Check out our calendar. The calendar is right here on our website at deukspine.com, live spine surgery. Go see the calendar. You can see what's posted for next week. And also don't forget about our the Deuk Spine app, which is great. I think it also has the spine surgery calendar in there. Diego says yes. And yeah, keep your eyes open for some more testimonials tomorrow. We'll see how these patients from today surgery did. They'll be in tomorrow morning for a checkup. Have a great night. Thanks for